A 55-year-old man, an oil mill worker, was brought to the casualty department of a district hospital with heavy perspiration, cold and moist skin, body temperature over 100 degrees Fahrenheit, weak pulse, hypotension, malaise and weakness, nausea and vomiting, extreme thirst, dyspnea and blurred vision. He was immediately admitted to the hospital and a CT scan was ordered, suspecting a cerebrovascular catastrophe. Only if the doctor on duty had asked the patient or his relatives one simple question: what exactly is the nature of his work? The doctor could have understood that he was suffering from a syncope with heat exhaustion. Effective history taking has long been identified as a core discipline in treating patients. Spending more time compiling a good patient history has been known to provide the most benefit as compared to long physical examinations and expensive laboratory tests. Collecting an incomplete history can affect initial therapy and all subsequent decisions for treatment. Therefore, it is essential that primary care physicians ensure that neither the patient nor the health system is unduly burdened by deficient history taking. Primary care providers and family physicians can play an important role in improving the recognition of occupational disease, preventing progressive illness and disability in their own patients, and contributing to the protection of other workers similarly exposed. This role can be maximized if physicians raise their level of suspicion for workplace disease, develop skills in taking occupational histories, and also learn basics of advising prevention. India is one of the major players in the global oilseeds and vegetable oil economy. With the largest area in the world under oilseeds like groundnut, rapeseed, mustard, sesame, safflower, and castor, about 27.9 million tons of oilseeds were produced in India during 2005-2006. The production of rapeseed mustard in India is about 7 million tons, which is about 12% of the world's total rapeseed mustard production. Oil extraction from rapeseed mustard is about 2.1 million tons per year. But the rapeseed mustard oil milling sector in India is a small-scale sector, as its activities are not regulated under any legal provisions. It has remained as an unorganized sector. These oil mills are using table ghanis and oil expellers for oil extraction, and they are situated in the oilseed growing areas, thus providing employment to rural people. Distribution of workforce. Oil mills and their laborers fall broadly into the following four categories. 1. Tiny oil mills in villages of India work on job work basis. Mill owner does not need to purchase oil seeds, nor does he have to sell any product. He simply crushes the oil seed on behalf of villagers and earns only job work charges. So there is no element of trading and marketing in this activity. Villagers go with their oil seeds and get it crushed in the tiny oil mills. The owners themselves are the workers in their mills and therefore are self-employed persons. 2. Medium-sized oil mills may be owned by one person or one family and may employ 50 to 100 persons working for the owner. Most of the workers may be contract laborers. 3. Big mills are corporate houses run and managed by professional teams. They usually employ full-time workers on their payrolls. 4. Women workers are mostly employed part-time or full-time, usually on lesser pay and for lighter jobs. Characteristics of work. Whatever be the activity, the following are the characteristics of the work in oil mill workers. 1. Noise Induced Hearing Loss, NIHL. The workers engaged in the workrooms of the oil mills are exposed to high noise, which have a detrimental effect on their health. 2. Accidents and injuries resulting from poor or non-existent safety standards are a common risk shared by small and medium oil mills. Often, workers may not be suitably trained on what could go wrong and on how to handle emergencies in case of fire or machine failure. 3. Skin problems as a result of sweat-induced reactions. Work in oil mills involve exposure to heat, and where there is too much heat and sweating, followed by too little evaporation of the sweat from the skin, miliaria rubra or prickly heat can develop and can give rise to bacterial or fungal infections. 4. Heat cramps. Working under extreme heat can have an adverse effect on the body, and the body may lose salt through excessive sweating. Heat cramps can result. These are spasms in larger muscles, usually back, leg, and arm. Cramping creates hard, painful lumps within the muscles. 5. Heat exhaustion. Heat exhaustion occurs when the body can no longer keep blood flowing to supply vital organs and send blood to the skin to reduce body temperature at the same time. 6. Heat stroke. Heat stroke occurs when the body can no longer cool itself and body temperature rises to critical levels. Heat syncope can develop as a result of overheating. Health problems and disease patterns. Hazards related to health and safety are more or less shared by all these activities. Oil mill workers are prone to a large variety of health problems. Ear, nose and throat or ENT conditions. Noise Induced Hearing Loss or NIHL. Noise disturbs the work, rest, sleep and communication and leads to accidents in industries. The long-term effect of noise is hearing loss. Causative source. The noise in the oil mills are dominated by low-frequency noise. The predominant noise sources in the oil mills are seed cleaner and power transmission system to oil expellers. Poor maintenance of machines and use of bamboo stick to prevent the fall of belt from misaligned pulleys are the main reason of high noise. Noise emitted by the electric motor, table ghani and oil expellers in all the oil mills are well within 85 dBA, which can be harmful to health. Injuries and other conditions leading to physical harm. Burns. Thermal burns due to explosions or scalds. Causative source. Major accidents have occurred due to explosions in boilers, leading to fires that quickly spread to poorly shielded gowns stacked with raw material or packaged edible oils. Crush injuries. Limbs may get crushed in crushing machines, or in some cases, death can also occur. Causative source. In some well-documented cases, the crushing machines that are used to crush coconuts and oil seeds may have issues with the pulley or the conveyor belts, and workers' limbs may get trapped in these areas when they try to push material inside the machines or try to disconnect the machines or the belts and pulleys. Heat cramps. Painful cramps in arms, legs or stomach which occur suddenly at work. Causative source. Dehydration induced by heavy sweating drains a person's body of salt, which cannot be replaced just by drinking water. Heat cramps are serious because they can be a warning of other more dangerous heat-induced illnesses. Ideal recommendations for health, safety and welfare of oil mill workers. Work practice recommendations include the following. Advise worker to follow the following tips if possible. 1. Convince the employer to provide some fans in the workstations. 2. Periodically spend time in a cool environment under a fan or outside. 3. Explain workers about heat stress. 4. Implement a buddy system where workers observe each other for signs of heat intolerance. 5. Provide adequate amounts of cool, potable water near the work area and encourage workers to drink frequently. 6. Be mindful about heat stress in summer months. 7. There should be provision of protective equipment like earplugs or ear muffs to prevent noise-induced deafness and simple mask. Prevention of occupational diseases and injuries. Preventive interventions require strategic contribution and efforts from government through occupational health and safety policy and legislation, cooperation from employers as well as workers, and advice from medical professionals. Occupational diseases manifest after long latency period from the time of exposure. There are challenges to establish and declare that a disease is due to hazard at workplace. Elaborate guidelines for management and prevention of occupationally caused diseases is beyond the scope of this documentary, as currently there is no mechanism for doctors to enforce their recommendation without a statutory backing. We therefore give general principles of prevention. Preventive measures should be designed and implemented at 3 levels of prevention. 1. Primary prevention aims to reduce the occurrence of disease by eliminating the cause of disease. For example, use of benzene-free solvents or solvent-free paints to eliminate the risk of carcinogenicity or reducing exposure to safe levels that prevent it from causing damage. For example, reducing noise at its source to levels that do not cause noise-induced deafness. 2. Secondary prevention to identify and treat health problems as early as possible, often before symptoms have developed, in order to take corrective action. For example, regular audiograms among workers exposed to high levels of noise in the work environment. 3. Tertiary prevention aims to avoid complications of and disability from illnesses and injuries and/or to provide rehabilitative and palliative care. It aims to minimize the consequences in persons who already have disease and depends on appropriate treatment. We expect that the primary care physicians already well versed with clinical knowledge for management of the occupationally caused health conditions. To learn more about detailed clinical perspective, treatment and prevention and control, please refer to ebook or printed version of BOHS for Informal Industry, Manual for Primary Care Providers. So, your next patient with any of the presenting symptoms we described earlier comes for treatment. Please don't forget to ask him the $1 million question. What exactly is the nature of your work?